Welcome to our webinar, Improving Sepsis Diagnosis and Management with Precision Medicine Tools. Sepsis Alliance gratefully acknowledges the support provided for this webinar by Immunexpress. The content in today's presentation is provided by the sponsor. And just as a reminder, the information presented today is intended for educational purposes only. So with that, I'm super excited to introduce Dr. Ken Remy. Dr. Remy, I'll now turn it over to you.
Thank you very much, and thank you very much to Sepsis Alliance for the invitation to present today. And certainly thank you very much for Immunexpress for also inviting me. I look forward to an engaging conversation. I have no financial disclosures to report. I do have a patent pending for LE-Spot technology, and I'm the CEO of Immune Functional Diagnostics. So we're going to take a little wind sprint together. We're going to go through diagnosis, disease evolution, theranostics, and then finally end on quality improvement, all areas really important, certainly for sepsis. I don't need to tell this group about sepsis, but as we do know, this is a threat that affects more than 11 million deaths worldwide. In the United States, 270,000 people are affected, and every 3.5 seconds, one person dies from sepsis. Now, one of the main challenges we've faced over the last 50 years is that this is a syndrome, and it has a clinical spectrum of its presentation, which encompasses fever, tachycardia, tachypnea, abnormal white blood cell, and evidence of infection. And so these systemic inflammatory response syndrome clinical signs in severity certainly lead towards decreased perfusion, persistent hypotension, and shock. I do want to call your attention to two different clinical cases. So in case one, we've got two, and case two, we've got two separate 4-year-olds with heart rates in the 135 and versus 115. You notice that both patients are febrile, albeit that case number one has an increased temperature compared to case number two. One patient, they both have the same respiratory rate. One patient is a bit more hypotensive than the other who is normotensive. They both have leukocytosis. Case one has ear pain. Case two has some challenges breathing with an X-ray suspicious for pneumonia. And if you look at their diagnosis, the person in case one actually just has an ear infection, yet they would meet criteria for sepsis, which is crazy to me. And number two, certainly that patient would meet criteria for septic shock. Clearly, our clinical diagnostic skills alone are not meeting the need to be able to really carefully discriminate, not just those that have sepsis, but more importantly, those that don't. So Houston, we have a problem. And so we've done a really great job over the past 20 plus years in reestablishing new diagnoses and new clinical definitions for sepsis that include in taking into account systemic inflammatory response syndrome, as well as a number of other clinical criteria. Undeniably, we have to have evidence or strong suspicion of infection. But here is a fundamental flaw, that there is inter-individual and time-dependent variability in both host response to infection that influence that clinical presentation. And to date, there's no real great reliable laboratory-based definitions that exist for the different stages of systemic response to infection to then come to an diagnosis of sepsis. Why do we care? Well, because we need to understand if a patient's septic or not septic, because it changes the paradigm by which we treat this individual. But if you don't have sepsis and there's not an infection, then we're not going to give antibiotics and increase antibiotic resistance. We're certainly not going to look at time to antibiotics if you don't have an infectious septic course, but you just have an ear infection. In fact, your virus may not require antibiotics, and other therapies certainly will be altered. So let's think about this. You've got a patient with an acute illness, and we're left with a decision tree. Is the patient infected or not infected? Do they have a bacterial viral infection? And then furthermore, is sepsis involved or not? And if sepsis is involved, is there a way that we can discriminate whether or not sepsis severity can be predicted? So for years, we've really looked at detection of bacteremia as our gold standard to try to see if patients have sepsis. People have looked for this holy grail. And the sad thing about it is we're not very good at growing bacteria in a bottle, assuming that only sepsis is caused from a bacteria. Procedurally, we have transient bacteremia. There's been intermittent or closed space or focal infections. And then sometimes we get persistent intravascular foci. But the problem is that most bacteremias in adults are less than 1 colony form unit per mil of blood. And so this has been extremely challenging to use detection of bacteremia in making your diagnosis. Furthermore, to take this even one step further, when we know whether we have a culture positivity or not culture positivity, there seemingly is no difference in outcomes. Whether you know the name of the bug or not and apply appropriate therapies in patients that do have sepsis, it may not matter whether or not you actually have detection of bacteremia. So lots of companies have looked at different ways to try to diagnose sepsis, especially on different samples of whole blood. And if you look at nucleic acid assays for the diagnosis, sepsisite, Viu, light cycler, septicite test, they've tried to look at detectable pathogens as a course. They've looked at their detection limit. And when you looked at their sensitivity and specificity, sadly, sometimes it was just slightly better than flipping a coin. Sometimes you had decent sensitivity, but the specificity was not nearly where it needed to be. And these tests at least detected different pathogens within a reasonable time frame, but as a standalone test didn't seem to garner muster towards where we were hoping. They had false positives, they had false negatives, and they were labor intensive and highly expensive. And these were rate limiting steps for where we went to or where we are today. So what is that holy grail test? Well, we need a test that can make the diagnosis, could hopefully identify severity of disease, and determine the likelihood of further deterioration with high accuracy and rapid turnaround. And this is our critically unmet need for hospitalized septic patients, because knowing this for timed intervention, antimicrobial treatments, whether appropriate or not, is critical to determine outcome. And I don't have an answer to you that there is a single test that will do this, but there are certainly tests now that are available and are coming down the pike that certainly are going to make this, I think, more feasible. So in 2022, we have a new market of precision therapies from Inflammatix and Immunexpress that use transcriptomic approaches that partner machine learning algorithms and score a likelihood of infection, including bacterial, viral, and then subsequently whether or not there's disease. Why is this important? Well, as I mentioned, factors that have hindered early detection of sepsis have been low sensitivity and specificity of our diagnostic options. Blood cultures, as mentioned, only have about a third of the time at best positivity to undifferentiated patients and are prone to false and negative and false positives with such a long turnaround of up to 48 hours. And certainly these delays have an impact on our antibiotic administration. So let's take a look at one of these tests from Inflammatix. So they use a 29 messenger RNA transcriptomic metric classifier. And what you're looking at here is a single center ICU of 200 surgical ICU patients with suspected sepsis or a high risk for developing sepsis. They collected their blood at 24 hours after sepsis diagnosis for this 29 messenger RNA transcriptomic metric classifier, and their outcome was estimating sepsis and 30-day mortality. Scott Brackenridge and et al. Did a wonderful job, at least, I believe, in this study in the ICU, and really be able to use this performance of biomarkers to determine that in this group, there was an AUC of 0.84. It produced a really high AUC and actually did better than previously existing biomarkers like procalcitonin, IL-6 and white blood cell count, although similar to procalcitonin. And so the challenge with this is that as a standalone, it wasn't as good as one was hoping for. And a follow-up study in critical care exploration, single center ICU, 335 surgical ICU patients with sepsis, you can see based off their severity of metric and bands, the transcriptomic here, for secondary infections as an outcome, the AUC was about 0.71 and 0.66. When you looked at 30-day mortality, it was only slightly about the same 0.66 and 0.68. So as a standalone test, at least in the ICU population in this study, as a standalone, it wasn't as good as one might hope. However, when you combined it with other clinical and biochemical indices, you actually grossly improved the actual predictability of this as an assay. And so combining these at 24 hours may actually predict adverse clinical outcomes with great accuracy. Now, this is in the intensive care unit population. So Tim Sweeney's group, the CEO of Inflammatix, has also explored using this in 6 emergency departments and almost 400 patients with suspected sepsis or infection. They collected the same blood at 24 hours for these 29 messenger RNA transcriptomics, and their outcome was 28-day mortality. And as you can see here, they drastically in this population, so earlier in the disease course, perhaps not as far as someone who makes the ICU, but those that are within the emergency room setting, they had, for IMX-SEV2, an AUC of 0.85. really actually pretty good to predict 20-day mortality and 7-day intensive care unit. When they partner that certainly with other indices, they got almost to 0.9 for 28-day mortality for an AUC. That's really promising. And so this test, though, is certainly in development. It's not FDA approved right now, but I think that there's some opportunities that this, with further expansion and better validation, might have promise. We're going to flip to septicide host response by Immunexpress. So their assay actually measures host response signals. It looks at mRNA and white blood cells and specifically quantifies expression in 2 white blood cell genes. And it's specific to infection in systemic inflammation. It's independent of the pathogen causing the disease, sepsis, and it's not reliant on even finding a pathogen in the blood sample. Now, the clinical interpretation is that it reports the likelihood of sepsis. It's independent of severity, and you get actionable results in about 100% of suspected patients. That's fantastic. And it's FDA cleared. It has cleared that major hurdle that most of these holy grail tests have failed to do, which tells you the scrutiny by which the data that they've presented to get to that point. It's got some really exciting news, I think. Number one, its actionable results are in about 60 minutes with their rapid septicite. So it gives you this likelihood of sepsis pretty quickly. And it's been evaluated in a number of different populations based off of these gene expression assays with their PCR measuring ratio of messenger RNA of 2 host response genes. When you look at the AUC for septicite rapid, it's quite accurate. It's about an AUC of 0.85. And when you look at this, this actually is promising, especially when you compare sepsis versus SARS. Now, what I really liked about this data that was in a preprint manuscript was that septicite outperforms procalcitonin and lactate. And if you look at this, procalcitonin and lactate have an AUC of a little bit better than a flip of a coin, with procalcitonin sitting slightly below 0.8. And when you looked at the septa score, which is bringing in the septicite genomic scoring system that the company uses, you can see here that that AUC gets almost to 0.9. So now you're able to have a score that has true positives and hopefully has true negatives when diagnosing patients with sepsis. And furthermore, you can imagine that if you were to partner this septicite with procalcitonin or lactate or other biometric or biomarker variables, you may actually get closer to that holy grail of an AUC of 1. What I really thought was interesting was that when you look at the septa score based off these 4 bands, so in band 1, it's got a low risk of sepsis in their proprietary genomic readout. When you have band 2 and band 3 and all the way up to band 4, you get this score. And when you're in band 4, you have a high risk of sepsis and a real high sensitivity and high specificity specifically to rule out sepsis and have just systemic inflammatory response, as you can see here, with a negative predictive value of 0.91, and a high specificity to rule in sepsis with band 4 with a positive predictive value of 0.81. This is really exciting because this test could actually help not just differentiate those that have sepsis, but more importantly, potentially allow people to look for other diagnoses that may be causing a patient to have non-infectious inflammatory syndrome that certainly derive and need other diagnostic evaluations. So, I think transcriptomics as a precision diagnostic really have promise. They're great at least, I think, being able to give clinical cues and being able to at least risk stratify those to reduce the potential to make poor septic diagnostics. It'll help us to reduce sepsis morbidity, reduce unnecessary use of antibiotics, and hopefully improve our resource allocation. But undeniably, there certainly needs to be further powering of most of these studies with clinical validation needed for every transcriptomic panel. And I would say that, as you saw with the inflammatics, the difference between the ICU and the ED, we certainly need to take into context the timing of disease for individual patients. But I think that if they're partnered with the right clinical variables, there certainly would improve our ability to diagnose and hopefully understand who's got the highest severity of potential deterioration. So now I want to move from diagnosis for a moment to disease evolution understanding. And to this group, this is not surprising that if you think about it, you've got multiple immune effector cells, and many of these cells in the undercourse, in the beginnings and sort of the middle and end of a person's enduring their sepsis course, has both pro-inflammatory and hypo-inflammatory conditions. And this does not just start with a pro-inflammatory state. That's old dogma that leads towards then hypo-inflammatory, because many of our immune effector cells are actually having different divergent host immune responses. And depending on the cell type, understanding which one predominates may actually inform our understanding of what therapies may in fact be helpful. Now, I know that sounds, what does he exactly mean? Well, let me explain it to you. So if you think about all of the different sepsis therapies over 50 years, and a lot of them, if you look at this no effect line of one, many of them actually were on the right of that. But to have 10,000 patients in each of these studies to detect a difference, to detect that there's a benefit for each of these individual therapies, it would be quite onerous and expensive. But one of the fundamental problems is that we've applied this one size fits all, that every single person that actually truly has sepsis, if they had sepsis in these studies, is the same. And I would posit that that's not true. And in fact, a lot of these failed therapies might actually work if they were applied in the right patients. And so we really need to have precision individual patient fingerprint development of their immune functional status in real time to be able to meaningfully apply and deploy a lot of these therapies that may actually have benefit. So let's go to COVID, something we all know. So the initial reports of COVID coming out of Wuhan, China, with 138 hospitalized patients, almost exclusively out of all of these early publications, lymphopenia, low lymphocyte counts, was certainly a finding that we saw in fatal COVID disease. And then as the patients evolved, we saw a rise in polymorphonuclear cells, thought to be possibly secondary infections. And this lymphopenia continued until death. And yet lymphopenia seemingly was different than what we were hearing about on the news, because a cytokine storm was the problem. These patients were on fire. They had this pro-inflammatory state. It's almost like we lost the idea of the last 50 years of sepsis in the beginnings of COVID, and started to believe that a single cytokine was driving a storm that was killing our patients. Certainly, I think it's a bit more complex, and I'm happy that we believe that, because a cytokine storm is an umbrella term, and it's non-specific. And if you looked at the IL-6 levels, which was used in COVID early, there was huge heterogeneity when you compared COVID ARDS compared to other ARDS studies. And so IL-6 certainly was not consistent across all of these patients with COVID. And what about that lymphopenia that I told you about from Wuhan, China, in those early reports? Well, John Weir's group at Penn certainly has defined immune expression as T cell exhaustion is a state of T cell dysfunction and could be non-specifically defined by lymphopenia. Wait, immune exhaustion, that's not cytokine storm or pro-inflammatory state. So perhaps there seems to be diametric or divergent host immune responses, and we're not really understanding this disease. And so our group, myself, Rich Hotchkiss, Monty Mazur, Isaiah Turnbull, Link Moldauer, Scott Brackenridge, and Chip Caldwell decided to study our COVID ICU patients against our septic patients. And we wanted to understand exactly what was going on in the immune system serially. And so the first thing we had to do was be able to recapitulate in panel C that lymphopenia persisted in our non-survivors, much like the data we were seeing from China. And then what we did was we measured IL-6 levels, and in red dots, those are non-survivors, black dots are survivors. You're looking on the x-axis of day 1 through day 15. And as you can see here, undeniably, IL-6 as a single analyte was twofold higher than in our septic patients when we compared to COVID patients. Okay, so there is a cytokine storm of a single cytokine, undeniably. And then we decided we wanted to look using our enzyme-linked immune absorbent assay, or ELISpot, which you take a 96-well plate, and you expose the plate, the cells in the individual wells, to a positive stimulus, such as LPS for TNF-alpha as a surrogate for innate function, and CD3, CD28 as a surrogate for adaptive function. And you should get a response. And so you can count the number and size of those spots to tell you the robustness of cellular response and function. And what was really interesting, especially in those that died, even compared to septic patients, is that the COVID patients had very suppressed T cells. They were paralyzed. And when you compared them with interferon gamma and TNF-alpha production compared to sepsis, these patients were profoundly paralyzed with their initial COVID responses. And so I bring this up because we also know that COVID pneumonia has two apparent clinical phenotypes. All the patients are hypoxemic, just like sepsis, right? You've got clinical definitions, you've got a hypoxemic patient, but that there are some that have high respiratory compliance and yet some that have low respiratory compliance. And yet in COVID, we were treating every single patient as if they were the same, just because they had the name hypoxemia associated with them and hypoxemic ARDS. Sound familiar to how we treat septic patients and how we lump everyone together rather than understanding individually what's going on with the patient at any given point in their serial disease evolution? How can we know which patients are going to have which responses? And how can we tailor therapies to an individual patient? I mean, if you think about it, some of the drug therapies that we used in COVID could actually be deleterious to some patients, because if you gave an immune stimulating drug to someone who was in a storm of cytokines, you actually could make it worse. And if they were suppressed and you gave them a drug that was good, like steroids that would further suppress them, you could lead towards secondary infections and inability to eradicate infection. And so we lack a method to immune phenotype patients. And I would argue that ELISpot is one precision medicine therapy and theranostic, where in a dish, we can look at a patient's whole blood. We can look at both innate and adaptive surrogates. We can then put different therapies applied to that dish to that patient in an ex vivo fashion. And then we can go back to the patient and explore this. And in fact, we did this. We did this in COVID. And what you're looking here is in the far left, CD3, CD28 positive stimulation for interferon gamma. And we'd run everything in duplicate. And you can see a panel of therapies, including interleukin 7, interferon beta, interferon alpha, OX40, and a checkpoint inhibitor. And this patient certainly had a benefit with IL-7, and we gave this gentleman IL-7. And so our group, led by Link Moldauer, Chip Coldwell, and Rich Hotchkiss, are certainly stratifying patient immune endotypes and sepsis, and try to use this precision medicine platform so that we can move this into patient practice. Not ready for prime time yet, but we hope to get there in the upcoming years. Now, why is this important? Why is it important to get the diagnosis right in the beginning and understand the disease? Well, by 2050, we're going to have more deaths from multi-drug resistant infections that's going to overtake cancer, diabetes, diarrhea combined. And the problem is we don't have new antibiotics coming down the pipeline. And so we need to actually hone in on giving antibiotics to the patient that actually has sepsis, rather than those that just have systemic inflammatory response from non-infectious causes. So because of this, I was fortunate that our institution embarked upon at least a quality improvement with Immunexpress, looking specifically at evaluation of septicite rapid in those that had suspected sepsis based off a sepsis code. And so we looked at our patients that had septic code prospectively in the hospital. We collected data before septicite, the septicite score was used, and after we initiated evaluation of this. And we compared it against the attainment of the 2021 surviving sepsis campaign for antibiotic administration and bundle endpoints based on likelihood of sepsis. Could a septicite score help us differentiate and improve our compliance with the bundles, especially for those that really do have sepsis, and understand perhaps those that don't? So here's your demographics before and after: possible infection, probable infection, definite infection. You can see what happened before and after this quality improvement. This is unpublished data. But what was really interesting was that we certainly did better with our bundle compliance after we used septicite as an indicator of whether or not the patient had sepsis. In fact, our greater than 30-hour bundle compliance was not nearly where it should be and only marginally got better, but certainly we can improve this. What I found most interesting is that when you looked at the septicite score, and if you remember, band 1 correlated with just SIRS, not sepsis, and the higher the band, or band 4 correlated with sepsis, we actually did better with those patients with compliance of the sepsis guidelines bundle that actually had sepsis, which tells you that somebody at the bedside must be saying, yeah, I don't think this person's septic, but yeah, they've got an ear infection and meet some criteria. We probably should give them antibiotics and try to use some of the bundle. Well, that's not a good way to practice medicine, but partnering it perhaps with an objective biomarker such as the septicite product may actually inform us to say this person doesn't have sepsis and we need to stop using antibiotics, and maybe we should start looking at why they actually have their fever, or why this patient has this decreased perfusion, because maybe they have a pulmonary embolism. And this would be really informative. And then as you can see, as we looked at individual bands, we had compliance similar in band 3 and band 4 that would certainly improve. So I think septicite in this case really was informative when we initiated this as a quality improvement project, because it helped us at least discriminate areas for improvement with bundle compliance, and quite frankly, unearthed an opportunity where we really need to use something more objective than just simple SIRS criteria and the possibility of sepsis. And I think that some of this data actually will be, as we move towards publishing it and refining it, will certainly inform the field. And so, as we recommended by the 2021 sepsis campaign guidelines, this quality improvement initiative is an ideal way to evaluate changes to a sepsis program. We know that a septicate score in the lower bands 1 and 2 correlate with a greater percentage of clinical assessments of none or possible sepsis, and it affords us the ability to look at non-infectious illnesses that masquerade as sepsis. And then a higher score correlated with a greater percentage of clinical assessments with probable or definite sepsis, and certainly gave us an opportunity to build upon and improve our attainment of the 3-hour bundle from the Surviving Sepsis campaign. So where do we go from here? Well, we have to move our syndrome into personalization. We have to develop stronger diagnostic and prognostic, and frankly, what I hope to show you guys with ELISpot utilization, the idea of a theranostic test that's grossly needed in my view to be able to apply therapies, hopefully to understanding the immune system in an individual patient. The only way we're ever going to get there, though, in sepsis is certainly by engaging not just those that are discovery scientists at the bench, but also engaging those that are doing all of these relevant fields in clinical and implementation science, artificial intelligence, and database, understanding environmental and social determinants of health that may skew a lot of the validation of these assays and how we need to understand the different populations. Undeniably, how we can take this into technology, new developments with certainly clinicians guiding much of the understanding of what happens at the bedside, and how we can move that to a bench in a meaningful fashion that informs both the discovery and future plans for these diagnostics. And we need to engage all points of interaction. So I think that individual patient signatures need to be evaluated rather than sweeping population generalizations of disease. I think that these new diagnostics can aid in diagnosis and can save us antibiotics, which ultimately by 2050 will save lives. I think these new transcriptomic evaluations may help diagnose sepsis more accurately and really can help define bacterial and viral infections and elucidate severity of illness. I didn't show some of that data today, but there's some nice data that's coming down the pike in both of the companies that I provided that really will help elucidate that. Sepsis is undeniably complicated. It's a heterogeneous set of host immune responses that could be further characterized into immune and clinical endotypes to inform our therapy, but we need to understand both conditions of hypo and pro-inflammatory states, which is paramount for effective therapy. And finally, let's stop making more clinical definitions and subclasses, and let's start defining the disease for actually what it does with functional immunologic, hematologic, and endotheliopathy tests in individual patients. And in my view, that's how we'll better understand to diagnose, understand the disease sepsis, and certainly we can move the field forward. And this is my laboratory and my 4 children that certainly have endured lots of sepsis talks and COVID. And with that, I am more than proud to take any questions.
All right, awesome. Thanks so much, Dr. Remy. That was a whirlwind of a fantastic presentation. So thanks for getting through it. Appreciate that. Folks, if you do have any questions for Dr. Remy, type them into the Q&A section. I'm not seeing any coming through right now. There was a question about cost, but I think we'll let the Immunexpress follow up on that one separately. And then there was also a question about slides. We will get an updated set of slides emailed out to everybody after the presentation.